Welcome to today's video on distinguishing between suicidal behavior from non-suicidal self-injury, or NSSI. This topic represents one of the most important clinical challenges we face in mental health practice today. While many health experts now largely accept that NSSI differs from suicidal behavior, significant challenges remain in understanding what exactly constitutes each behavior and how they truly differ from one another. Distinguishing suicidal behavior versus non-suicidal self-injury. Historically, there has been substantial confusion and obfuscation around these behaviors, which has complicated research efforts, assessment practices, and treatment approaches. This confusion has real clinical consequences. It affects how we assess risk, how we intervene, and how we understand prognosis. The proposed DSM-5 NSSI disorder criteria represents an important step forward that should help improve these nosological difficulties and enhance the precision of our research. The key takeaway from today's presentation is that clear distinctions between these behaviors are absolutely essential. They are essential for accurate assessment, for providing appropriate interventions, and for conducting meaningful research that can be compared across studies and settings. Without these distinctions, we risk both over and under responding to our critical presentations, potentially putting our clients and society at risk. Functional differences: why people engage in non-suicidal self-injury. Understanding why people engage in these behaviors provides another crucial layer for distinguishing them. Non-suicidal self-injury functions are fundamentally life-preserving in nature. The research consistently shows that NSSI is primarily motivated by desires to regulate aversive internal states, specifically to reduce negative emotions, engage in self-punishment, or generate some type of feeling when people feel emotionally numb. The empirical data on this pattern are quite consistent. Research shows that individuals report increasing narrative affect before engaging in NSSI, followed by significant relief or positive effect afterward. This pattern has been confirmed not just in retrospective studies, but also in real-time electronics diary studies that track emotional states before and after NSSI episodes. Importantly, some individuals specifically report using NSSI to prevent or avert these behaviors can serve different functions, however. Suicide attempts, in contrast, tend to be primarily motivated by intensely strong desire to escape or die or to unburden others. While both behaviors ultimately aim to modulate psychological distress, the dominant intent differs significantly between the two groups. Suicide attempts are more escape-oriented, while NSSI is more regulation-oriented. This distinction has important clinical implications. Understanding whether someone's primary motivation is affect regulation versus escape helps guide our intervention approaches. For NSSI, we focus on building effective regulation skills and alternative coping strategies. For suicidal intent, we focus on safety planning and addressing the underlying desire to escape or die. The functional analysis becomes a roadmap for treatment planning. The continuum versus categorical debate. There's an ongoing conceptual debate in the field about how to best understand the relationship between these behaviors. The continuum model proposes that self-harm exists along a spectrum ranging from mild indirect behaviors like occasional binge drinking to moderate direct self-harm like bruising or burning to severe harm like cutting, ending with lethal harm or suicide. This continuum model has validity because it recognizes that behaviors can co-occur, share some common features, and risk correlates, and helps us understand the potential progressions from lesser forms of self-harm to more severe forms. Some research supports this progression model, particularly Thomas Joiner's theory about acquired capability for suicide through exposure to painful experiences. However, the categorical model argues that there are distinct behaviors with different intents, functions, and treatment needs. The high co-occurrence between these behaviors complicates this classification, but research has identified subclasses of self-injurers with differential relationships to suicidal behavior. Some self-injurers rarely progress to suicide attempts, while others do show this progression. The important clinical point is that both models have validity and serve different purpose. We can use continuum thinking for understanding progression risk and long-term trajectories, while using categorical thinking for immediate clinical decisions about safety and interventions. They're not mutually exclusive approaches. They answer different clinical questions on both, and both contributing to our understanding. Prevalence and age patterns. The prevalent data reveals striking differences between these behaviors. Non-suicidal self-injury shows consistently higher prevalence rates across all population studies. In the community adolescent samples, lifetime rates typically range from 13 to 28%. Among college students, the rate can be even higher, ranging from 12 to 37%. In clinical samples, the rate can reach up to 80%, reflecting the concentration of more severe cases in treatment settings. Suicide attempts show much lower prevalence rates. Yearly rates in adolescents hover around 8.5%, and lifetime worldwide prevalence is estimated at only 2.7%. This represents a substantial difference in base rates that has important implications for screening and assessment practices. Interestingly, the non-suicidal self-injury prevalence rates show remarkable consistency across international studies and different regions, while suicide rates vary significantly by culture, country, and region. This suggests that non-suicidal self-injury might be less influenced by cultural factors than suicidal behavior, though more research is needed on this point. The developmental course also differs meaningfully. The NSSI typically begins earlier, around age 13, compared to suicide attempts, which typically begin around age 16. Both behaviors peak during adolescence, but their trajectories diverge afterward. NSSI appears to decrease with age after middle age, while suicide risk actually increases with age in most countries. This earlier onset of non-suicidal self-injury, combined with its higher prevalence, makes it a critical target for early identification and prevention efforts. If we can identify and intervene with non-suicidal self-injury early, we may be able to prevent progression to more severe outcomes. Methods and lethality. Critical distinctions. The methods used and their associated lethality provide some of the clearest distinctions between these behaviors. For non-suicidal self-injury, cutting is by far the most common method, typically performed on low lethality body sites like the forearm and upper legs. Other common methods include skin abrading, interfering with wound healing, or banging or hitting oneself, and burning. What's particularly notable is that the repeats self-injurers typically use an average of 4 different methods, and method diversity actually correlates with frequency of the behavior. Despite the often high frequency of non-suicidal self-injury episodes, sometimes exceeding 100 separate episodes, very few individuals require medical attention for their injuries. This highlights the inherent low lethality nature of non-suicidal self-injurious behaviors. People engaging in NSSI seem to intuitively understand how to injure themselves without causing life-threatening damage. Suicide attempts present a very different pattern. The most common methods are firearms, hanging, and poisoning or overdose, all high lethality methods. Cutting actually accounts for less than 1.4% of suicide deaths, and when cutting does result in death, it typically targets high-risk anatomical locations like the jugular vein or carotid artery. The individuals who attempt suicide are much more likely to require medical attention or actively seek help. These method differences aren't just academic, they have immediate clinical implications. When assessing someone, we need to document the method, location, and medical consequences precisely because these details drive our risk stratification decisions. The specificity of these details can help us differentiate between behaviors and assess relative risk levels. Psychiatric and personality differences. The psychiatric profile associated with these behaviors show important differences in both the prevalence and severity of mental health conditions. For suicide attempts, research consistently shows that 94 to 98% of individuals meet criteria for at least one psychiatric disorder. It's quite rare for suicidal behavior to occur in the absence of significant psychopathology. This suggests that suicide attempts typically occur in the context of substantial mental health impairment. Non-suicidal self-injury shows a different pattern. Only 22 to 40% of individuals in a community sample meet criteria for a psychiatric disorder, meaning that a meaningful portion of individuals who engage in non-suicidal self-injury show no clinically significant mental health dysfunction. That doesn't mean NSSI is benign or that these individuals don't experience distress, but rather that non-suicidal self-injury can occur across the broader spectrum of psychological functioning. Both behaviors are associated with depression, anxiety, and substance use disorders, but suicide attempts show stronger association with the mood and substance use disorders specifically. This suggests different underlying vulnerability patterns. Regarding personality factors, both behaviors are linked to impulsivity, but the evidence suggests a stronger association between impulsivity and non-suicidal self-injury. Non-suicidal self-injury episodes often occur within 1 hour of urge onset, despite individuals' attempts to resist these urges. The concept of negative urgency, the tendency to act impulsively when experiencing negative emotion, appears particularly salient and important for non-suicidal self-injury risk. This has immediate clinical applications. We need to assess both trait impulsivity and situational urgency patterns. High negative urgency can indicate immediate non-suicidal self-injury risk and potential for escalation, requiring more intensive monitoring and skill-based intervention focused on distress tolerance. Cognitive patterns, problem solving, and hopelessness. The cognitive patterns associated with these behaviors reveal important differences in how individuals think about and approach their problems. Suicidal individuals consistently show problem solving deficits in research studies. They generate fewer potential solutions to problems, and the solution they do generate tend to be less adaptive or effective. They also show more constricted and inflexible thinking patterns, which can contribute to the sense that suicide is the only solution to their problems. Individuals who engage in non-suicidal self-injury show a different cognitive pattern. They can actually generate numerous adaptive solutions to problems, similarly to control groups. However, they struggle with choosing among these solutions and believing that they can actually implement them effectively. They also tend to use more avoidant coping strategies and are less likely to utilize social support even when it's available. The most significant cognitive differentiator is hopelessness. Hopelessness is consistently identified as a critical risk factor for suicidal behavior, but it's much less common among non-suicidal self-injury groups. This makes theoretical sense. Individuals who are suicidal often think dichotomously and believe their pain cannot be relieved, making suicide seem like the final answer. In contrast, people who engage in non-suicidal self-injury maintain a sense of control and perceived ability to change their direction. Self-injurers consistently show greater attraction to life, more reasons for living, and more future-oriented thinking compared to those who attempted suicide. As the research notes, non-suicidal self-injury occurs over distressing situations, and this perceived control is directly opposed to the experience of hopelessness. This has critical clinical implications. If we see hopelessness beginning to increase substantially in someone who engages in non-suicidal self-injury, this should trigger immediate suicide risk assessment and safety planning. Rising hopelessness can signal a potential shift from non-suicidal self-injury to suicidal behavior. Abuse histories and family environment. Research reveals interesting patterns in abuse histories that can help differentiate these behaviors. Sexual abuse appears more strongly associated with suicide attempts, particularly among women diagnosed with borderline personality disorder. Physical abuse, however, shows a stronger, more direct relationship with non-suicidal self-injury, and this relationship persists even when other clinical and psychosocial variables are controlled for. That doesn't mean that sexual abuse is irrelevant to non-suicidal self-injury. It can be a marker, rather, for more severe chronic forms of NSSI rather than a primary predictor. The type of abuse history can provide information about risk patterns and potentially inform on treatment focus. Both behaviors are influenced by negative and invalidating family environments characterized by poor functioning, frequent conflicts, and a lack of cohesiveness between family members. However, parental criticism appears particularly salient for understanding pathways to non-suicidal self-injury among adolescents. There's something specific about critical invalidating family environment that seems to contribute to non-suicidal self-injurious risk. These patterns suggest we should assess abuse history comprehensively, but recognize that different types of trauma may contribute to risk for different behaviors. Physical abuse may indicate higher risk of non-suicidal self-injury, while sexual abuse may indicate higher suicide risk, though both can co-occur and interact with other risk factors. Understanding family dynamics and trauma history helps us understand the developmental pathway to these behaviors and can inform our treatment approach. Trauma-informed care became essential, but the specific focus may differ based on the type of trauma and its relationship to the presenting behavior, whether it be non-suicidal self-injury or suicide attempt or suicidal ideation. The critical relationship, non-suicidal self-injury as a suicide risk factor. Despite being distinct behaviors, NSSI and suicide attempts show a concerning empirical relationship that we must understand for effective risk assessment. Research indicates that up to 85% of people who attempt suicide have a history of non-suicidal self-injury. From the other direction, estimates suggest that up to 70% of individuals with a history of non-suicidal self-injury may attempt suicide at some point in their lives. The relationship is so strong that non-suicidal self-injury increases risk even after controlling for other known risk factors like suicidal ideation and depression. Studies of college students show that those with non-suicidal self-injury history are 8 times more likely to consider suicide attempts and 25 times more likely to attempt suicide. These are substantial risk multipliers that we cannot ignore. Growing evidence suggests that non-suicidal self-injury often precedes low suicidal behavior temporally. Longitudinal studies demonstrate that non-suicidal self-injury prospectively predicts suicide attempts more strongly than many other established risk factors. The typical pattern shows NSSI onset occurring 6 months to 1 year earlier than suicide attempts, suggesting a potential developmental progression for some individuals. This relationship has immediate clinical implications, and we must treat any history of non-suicidal self-injury as a meaningful predictor of future suicide risk. This does not mean that everyone who engages in non-suicidal self-injury will attempt suicide. They won't. But it does mean that non-suicidal self-injurious history elevates risks sufficiently that we need to evaluate marker risks and monitor for progression indicators. The challenge is determining which individuals with non-suicidal self-history are at a highest risk for progression to suicidal behavior. This is where understanding severity marker becomes crucial for clinical practice. Severity markers and risk escalation. Not all non-suicidal self-injury carries the same risk for later suicide attempts. Higher frequency is linked to greater risk. 5 or more episodes meaningfully raise risk, and 20 or more are strongly associated with future suicidal behavior. Using more methods may also predict escalation and may signal broader, more severe self-harm patterns. Specific red flags include low or abstained pain during non-suicidal self-injury episode, causing more tissue damage than intended, and when NSSI begins to interfere with school, work, or relationships. Longer duration of NSSI is associated with higher likelihood of attempts. The habituation hypothesis suggests repeated painful exposure can increase the capacity for lethal self-harm over time. Clinically, increases in frequency, severity, or method diversity should trigger immediate reassessment and safety planning. Assessment implications. Assessment must be a multi-domain and ongoing because intent can change quickly. Directly assess desire to die, ambivalence about living, and any planning in addition to functions such as affect regulation and interpersonal motives. Capture mood details, techniques used, body location and preparatory behaviors, and context around the episodes. Systematically record severity markers including frequency method, diversity, tissue damage, pain experience, and recent changes. Be aware of challenges such as fluctuating intent, retrospective bias, mixed motivation, and disclosure limits due to stigma. Use validated instruments when available and prioritize concrete behavioral details over labels. Treatment and safety planning implications. Treatment should target the primary functions of the behavior while maintaining vigilance to force suicide risk. For non-suicidal self-injury that serves affect regulation, prioritize skills training in stress tolerance and emotion regulation, and build alternative coping strategies. Do not assume suicidal intent by default because unnecessary restrictive responses can be counterproductive, but monitor closely for escalating or rising hopelessness. Safety planning should address both NSSI implements and highly lethal means, tailoring interventions to the level of risk. Escalation signs planning or clear intent requires urgent intervention and higher levels of care. Successful treatment reduces reliance on non-suicidal self-injury while keeping the individual safe and healthy. To conclude, future research directions. Progress requires more longitudinal studies that map non-suicidal self-injury and suicide pathways across development and cultures. Move beyond simple demographic contrast toward interactive models and symptoms-based profiles that explain mechanisms of escalation. We need stronger research on resilience and protective factors to understand why some high-risk individuals do not progress. Greater clarity on the lifespan course of non-suicidal self-injury and systematic comparisons of community and clinical samples are essential. Methodological consistency, shared datasets, and harmonized definitions will improve comparability and accelerated discovery. The goal is to produce developmental models that directly inform preventions and targeted early interventions. To conclude, thank you very much for your attention during today's presentation on distinguishing non-suicidal self-injury from suicidal behavior. I hope this information has been helpful in clarifying these important clinical distinctions and their practical applications in assessment and treatment. I want to acknowledge that the information presented today relies heavily on Chapter 3 of the Oxford Handbook of Suicide and Self-Injury. This comprehensive handbook represents one of the most authoritative sources in our field, bringing together leading researchers and clinicians to synthesize current knowledge about these complex behaviors. I encourage you to consult these resources directly for more detailed information and additional references as we continue to advance our understanding of self-injurious behavior. Remember that careful assessment, evidence-based interventions, and ongoing attention to safety remains the primary responsibilities for clinicians. The distinctions we've discussed today should enhance rather than replace clinical judgments. Thank you again for watching, and I look forward to seeing you in my next presentation. Take care, and remember that continued education and evidence-based practice are essential for serving society and dear viewers effectively. Thank you.